Many thanks for staying tuned. It's still the conversation on Lagos Television, and this morning we will be having taking a look at ending maternal mortality in Nigeria. And of course, this conversation is one that is really coming at a time where Nigeria still remains one of the countries with the highest number of maternal mortality. It is said that about 1,047 deaths per 100,000 live births, and that is huge. We do have a doctor in the house this morning whom together we'll be taking a look at how do we begin to make conscious effort at, if not ending, reducing drastically the number of maternal deaths we record here in Nigeria. Join us this morning as a welcome, Dr. Temidayo Giwa. Thank you for being here on the program today.
Good morning.
Good morning. All right, Dr. Giwa, let's quickly get into this. Ending maternal mortality in Nigeria. Is it possible we put an end to this, or should we begin by ensuring that there is a reduction first before we start looking at ending?
Okay, first and first, it's not a new subject. I mean,
Sure.
When I was in med school in 1999, I was doing my ops and gyne posting. And I remember something that caught my fancy was how high our maternal mortality rate was then.
In 1999.
By the grace of God. Looking back now, that's over 26 years or so. Where we are now, it's unbelievably much more than then. According to WHO 2023, we have the second highest in the whole globe.
After India?
Not really. After South Sudan. It's so interesting that your point is so valid, because if you now take our number, 1 in every 4 pregnancy-related deaths happen on Nigerian soil.
On Nigerian soil?
1 in every 4. Because now we are having as high as 1,047 in 100,000 pregnancy per year.
Per year.
Per year, that's important. So our population of over 200 million, we now escalate that. And it is documented that 1 in every 4 pregnancy-related deaths on Earth happens in Nigeria.
So if that was the situation in 1999, and we're in 2025 now, and the number kept increasing, is that does that indicate that there are no actionable plans being implemented by all tiers of government, especially the one at the local level?
Okay, so basically your question is very germane. Our problem is not that we don't have policies. There's a lot that's been going on, and I must start by acknowledging the activity of our sitting governor in Lagos State, His Excellency Sanwo-Olu, who has started a plot that if you're pregnant and you subscribe, you can almost get your pregnancy through at no dangerous cost. You can get C-section at no cost to you, which is actually working. So it's not that we don't have attempt. I should say quickly, the problem is not the same across board. It's worse in some areas compared to others. You notice I said South Sudan are the highest in the world. Why? They're in war-torn area consistently. So what's happened, Boko Haram, all that, has also increased the incidents, especially in the northeastern part of Nigeria. In fact, for record today, the rates in northeastern Nigeria is about 1,540, other than the general 1,047 in the global, in Nigerian state. So that shows that also is contributing to the crisis. Of course, in Lagos, it won't be as bad as in the interiors. Even in Lagos, Lekki won't be the same as Makoko, obviously. So these are the discrepancies that we need to deal with. I've said 2 things. Policies are on the way. There are effects, but it's a small drop in a beautiful big ocean.
Right. So, I mean, from what you said, it broke my heart that you said in 1999 the situation was this way, and now it is worse off. Would have thought that by, between then and now, that all actions would have been a little, at least we could have been saying differences in numbers and all of that. So, is it just about the facilities or the personnel also involved, or why do we keep having an increase in the number of women who die from complications from childbirth or pregnancy-related issues? Or is it lack of proper education, proper access to medical care? Or why does this problem persist this way?
All you have said are reasons, and one
All.
is not more important than the other. But the challenge is that I tell people that care to listen, we have a medical emergency. We have an emergency state in the medical sector. There are 3 layers of problems that we can't deny. We'll start from our clients, our patients, our pregnant women. For somehow, for cultural reason more than even economic reason, some part of the country doesn't just feel it's comfortable to come to the hospital to deliver.
Okay.
There is again say that if you go to the hospital, they'll call you open, so don't go there, especially in the interior. So they rather go to traditional birth attendants, and some feel that in Yoruba land, I'll use the right word, we say, one baby, so why do you want to take
To
delivery
open
for me?
of
Yeah,
human.
delivery process should be automatic
In
if
quotes.
everything is normal. But if anything goes wrong, somebody must be able to pick it first in advance and then deal with it. Practical. This morning, I walked before I set out. I scanned a lady who was 24 weeks pregnant. And the pregnancy is in the abdomen, not in the uterus.
Wow. 24 weeks.
Yes. Life. My colleagues will be hearing probably. So if she there falls into labor, the obvious is clear. She's been pregnant. She's been doing scans, obviously,
So
but
that-
nobody picked it.
That's why nobody picked the fact
Till
that
now.
24 weeks. It was only picked this morning.
It was picked by junior colleagues that now, and colleagues, the gynecologists that now
Okay.
escalated to me, please confirm what we're finding.
At 24 weeks.
2 days, today, this morning.
So what are the odds?
The odds are God will take control.
Oh no.
Take control. Okay.
I don't mean
Jimola,
that
I'm sorry.
negatively.
No. Again, isn't it part of the problem? We seem to always hand everything to God, when ordinarily that is why there are doctors.
Okay, so I don't want to go into details for obvious reasons. My colleagues, competent hands, are taking it from here. When I
Agreed.
say God will take control, I'm just trying not to make a scene of
Out
it
of
because
it.
she's probably listening too. So the point is, yes, at least it's good enough. This is one of many that probably won't even be picked till she falls in labor. At least now that is some light at the end of the tunnel. We're having specific conversation, don't forget that. At the level of client, they also don't even come at all. That's on one side. I don't want to flog that more. Let's go to the next level, and I'll be very blunt, we doctors and caregivers.
Okay.
There are multiple layers of problem there. Job satisfaction is next to zero, and please don't blame them, including me. You don't want to know how much a professor of medicine is earning per year. It's demeaning. That's the truth. So you see, some people tell me that they like doctors, they can do more than one job. And I say, no, that's not to love us for. Why do I want to do more than one job if my one salary is appropriate for me? So it's somebody, a doctor that set out in the morning and had to go to 3 places before he can keep body and soul together. At the last thought, he's already gone and out, obviously. So patients will have the relics of him. So that's one of the problems. Can we increase the salaries of doctors? Yes and no. Because we also need to talk, I'm a very objective businessman, we also need to talk about productivity.
Right.
How much is our teaching hospitals making? How is that translating to paying staff salary? Are we looking into all these details? So in the medical sector, there is a lot of things to be dealt with. Doctors' job satisfaction, jobs being focused on salary, and a lot of other things. Of course, that's doctors. What about nurses? What about all those sectors? What about midwives? All this must be dealt with at the level of personnel. Of course, that's on one side. What about equipment availability? That's actually alarming. I remember when I was in med school in 1999, then we have one of the most gifted ministers of health we've ever had, Olukoyeransome Kuti, and he was very particular about primary health care. I remember then in Loring we do COBIS. We go to the interior to learn how things are real time there. And it was a good idea because he also helped the medical sector. We need to go back and be more focused on primary health care at the government level.
Okay.
I must also say the current minister is doing excellently well. I must give it to him. He's here to really work in the health sector. He's doing a lot. I'm impressed with the work, but a lot of time has been lost. We need to pick up from where we stopped and buy the time, because time is of essence. Now, government also need to please live by the thing we agreed in Abuja that year, that 15% of budget should go into health. We've not been able to achieve that since that was done in our home backyard in Nigeria, especially in Nigeria. So these are layers of issues that need to be addressed.
Okay, from your narrative this morning, the problems that we are facing is quite complex, even though your tone is soft, but the problem is big. In terms of personnel, would you say that brain drain has also contributed to the increase in the number of maternal mortality that we have in the country? Then I imagine the situation that you painted this morning about that lady. If such should have happened in our rural areas, even outside of Lagos, in some other part of the country, then it's as good as she will be gone. So do we have adequate personnel in our rural areas to undo complications like this? And then the factor of brain drain, how much is it contributing to this maternal mortality rate?
Unfortunately, the reality is in our face. Doctors are leaving en masse. That's a fact. Because, let's be real, if I cross the border to Benin, for example, by road, I'll probably end up what I'm earning now. That's a fact. Because we're talking about our currency difference.
Right.
They didn't increase their salary in Benin, but the depreciation in Naira will make me earn more by just crossing the border here, just there. So these are real issues. When we always talk about things, we must realize economics is real. Why shouldn't I drive a Range Rover now? Why should I wait till when I get to heaven to drive a Range Rover? Those are realities. So we can't dispute the fact that the drain is real. I must say Dr. Pate is doing a lot in that regard, but it's a long thing. People are still planning to leave as we speak.
True.
People are writing exams to get out of this country as doctors and even nurses. Don't let's miss words, because it's more productive. We are all humans. Demand and supply pays here, and economics says it. We are all greedy by nature. That's sorted. Now, this problem is not new. In 2007, I was serving in Abia State, and I remember then I had to travel from the state capital to Isikwaso local government, because the old local government will only see me, a fresh doctor, as the only doctor in the public sector, and my colleague Ben, by the way. We traveled there to see them twice a week, and that's the only doctor they will see at the local government level.
Twice a week.
Just as for me and him also twice a week. So our CDS is off. NYSC sent us there to support them. My point is that bad in Abia State in 2007? I don't know what's going on now, but the reality is that all of that brain drain, doctors are far and apart. Remember, Lagos hosts more than half of doctors in Nigeria today. Fact.
Right.
Lagos State, as we speak, more than half of doctors in the old Nigeria area is here in Lagos. And it makes a lot of sense. And in fact, still Lagos doesn't have enough doctors. So it's a real deal. Now, beyond that, I must be blunt, the training is also reducing in quality.
Right. Doctors training? Doctors
training, we have to be blunt about this so that we can move away from here. And it's a multifaceted problem. Very multifaceted. We are distracted more than we were some years when I was in med school. And excellence has found its way to pass through the back door across our country. It's a national decay, whether we like it or not. So competence is really, really a problem. Beyond that, number is also a problem. So it's a double layered problem. And then, of course, equipment also need to be looked into.
Right. So from all of the issues that you've raised, because now can we also come back to the people themselves, the mothers themselves, the pregnant women themselves? How much of culture shock or culture barrier are we still facing also when it comes to issues around ending maternal mortality? You did say something earlier. It seems like it was a joke, but here a lot of people also take that, you know, into factor. People don't want to go through CS. People don't want, you know, they always say you would deliver like the Hebrew woman.
Yes.
And when, you know, you hear issues around CS, it's more or less like a death sentence. And people will say, no, I don't want to do that. Some people will say, no, I can't afford to go through a blood transfusion when there's a problem. So how do we get away from these culture shocks, those beliefs, and how much danger are they posing to this issue?
There is no society without a cultural system. I tell you from the depth of my heart, no culture is either good or bad. All cultures are both good and bad. Our work is to sieve out which one is productive and progressive, which one is not. The layer of your conversation is valid. Let me go a bit deeper. In the northern part of Nigeria, especially northern eastern part of Nigeria, where they had the highest anyways, there are layers of cultural issues you quite did not even touch.
Okay.
The mother-in-law pregnant woman issue. The mother-in-law's decision is final, unequivocal. Whatever she says is final.
It's final.
That's one. And the mother-in-law is definitely not educated.
So if she says no hospital birth,
Period.
then that's it.
That's on one side. The husband also has the final say. So it's not a pregnant woman's decision to make in that side of the country. Beyond the cultural barrier, there is also economic barrier.
So poverty is also...
It's deep. What I say, you are in Lekki, for example, you're a working class pregnant woman in Lekki, and they say, please, you need to do 4 pregnancy scans in duration of your pregnancy. You do 40 effortlessly. How much is it? 7,000, 10,000. That's peanut. But somebody that is a minimum wage is not 70,000, for example, and you said you should do 4 pregnancy scans in the she can't afford it, period. So even if she wants to, she can't. So those are deeper issues. So I will start from that level. We need to empower women. That's the first thing we must not forget. I say it with all sense of seriousness. I'm a feminist and I'm unapologetic about that. We cannot solve this problem till we empower women. Of course, I should also say, culturally, child marriage and subsequent teenage pregnancy is still real in Nigeria. And that increases maternal mortality. Beyond that, abortion, safe abortion, and policies against it should be looked into.
Right.
All this is beyond what you said is valid.
Right, but all of these issues are also issues that are there.
So it's not as much as an issue with our women. No. The society is actually stiffly against them. I'm sorry, but that's the truth. A lot of things are working literally against them at different layers. So I will challenge all of us from family. Please, let's empower women. Our children, our girl child, send them to school, empower them to have a means of making their own living. And then that will go a long way to reduce maternal mortality rate. And also I encourage the family circle to not see women as inferior. They are not in any way inferior. In fact, the world will not go around without them.
Okay, talking about the layers of problem that we have when it comes to maternal mortality, we also have different layers of government. We have the federal, we have the state and local government. Are there significant steps that they are taking towards addressing this problem? And then the new Safe Motherhood strategy of the Honorable Minister of Health, Professor Mohammed Pate, have you taken your time to study it? And is it going to take us out of this problem?
Okay, so first things first, I said it earlier. A lot has been done, and I'm saying it again. A lot has been done. Are they visible enough? And they are being done. Okay. We shouldn't miss that. I mean, if we do that, we're not doing justice to this interaction. However, is it enough? The stats are against that. That's a fact, you know. So one thing I will tell, at the federal level, at the state level, at the local government, a lot is done, especially in my beautiful Lagos state. I can give it to the structure. They're doing a lot. As I said, Professor Pate is also trying. But the issue is, the main issues are in the far away, dilapidated, inferior local governments. I remember one of the things in that article you describe is one local government has been earmarked as those that are accountable for about 30% of all maternal mortality rates in Nigeria today. That's progress for me. At least we now know where to focus on. And as I said, northeastern part is worth it. And don't forget, they are still war-torn. Whether we like it or not, there are still IDPs. People are pregnant in IDPs, isn't it? There are IDPs that the primary care is not even working at all, and people are pregnant. So it's a major, complex, multifaceted national issue. At the state level, Ekiti State came out recently and gave us reasons to believe by data that we're making progress. Is it Ekiti? Yes, I think it's Ekiti, if I'm not wrong. But my point is that even one of the issues I'm raising is the data. Where is the real data to work with? So we have a lot of things to do. I break it down. Of course, non-governmental organizations outside the country are also doing a lot. That should also be mentioned. From USAID to UNICEF, WHO, a lot is going on. But this is my own opinion. Measures cannot come from without. Whatever is happening, we doctors especially, because we are the forerunners of this, we should ask ourselves, what are we planning to do? Because this is really, really not a joke. Beyond doctors, what are we doing at the communal level, at the community level? Because whether we like it or not, the traditional leaders are always around. And these are realities in their area. So we need to put our hand on deck and get beyond what the state, federal, and local government is doing to what are we doing at the community level.
Okay. From what you've said now, how do we also begin to incorporate the TBAs? And because they are also one of the people that, of course, the women would go to. And as much as Lagos seems to be an urban center, there are people who still believe in the TBAs more than they will believe in regular doctors. Yes. And I know that Lagos State Ministry of Health is also incorporating the TBAs, but how much of incorporation do they really need so that there are also, some places in Lagos State that are considered as the interior or the community levels. So how much of collaboration should government, have with the TBAs?
First things first, whether we like it or not, it's all about demand and supply.
Sure.
And as it taught us in our economic class, the higher the supply, the lower the cost. The lower the supply, the higher the cost. So there is no doubt about it. Doctors are not enough. Midwives are not enough, and they will not be enough in the circumstance we are in now. So going to traditional birth attendant, we don't have a choice, actually. Right. So, but how much of collaboration we could do is also a function of how much are they willing to collaborate. I say, when I was doing my psychiatric posting in the University of Ilorin, my psychiatric tutor told me that traditional medical practice has advantage in psychiatry, and they listed the advantages. I won't go there now. But my point is that the collaboration is actually meant to be win-win. It has to be mutually beneficial. How much are they willing to collaborate with us? Okay. How much are we willing to understand where they are coming from so that we can meet halfway? The bottom line is then justifies the means. How many lives are we willing to save by compromise? Because I said it right. There are reasons why people will want to go to traditional birth attendants. Sure. And it's their choice, actually. You remember, in India currently, if you go to an hospital, they will ask you, what do you want, orthodox or traditional?
So there's a choice.
You have a choice at the Indian medical level. Of course, we're also doing there's a lot of collaboration in there. We now have an association of our medical practitioners, actually. But how much are we willing to translate that to reducing maternal mortality rate is where information must fizzle out, and we must come down to their level. Right. They're not going to come to our level. Our now will be orthodox.
Okay.
Okay. Earlier I mentioned the new safe motherhood strategy of the federal government. The implementation is always the problem that we have in these parts of the world, and I know the federal government is trying to re-equip some of our primary healthcare centers, according to Professor Pate. So some of these actions they are taking here and there, are there timelines, short-term, long-term, and medium-term, that are visible enough for you to see towards addressing this problem?
Okay, so the issue on hand, coming here and spending some time here, I like the way Albert Einstein puts it. He said the level we have when we create a problem is not the level we stay to solve it. The level of reasoning, actually, he was talking about. So I need us at this level to be real. Professor Pate is doing his best. He has an immediate 4 years and probably subsequent 4 years to carry out what he's thinking, and then continuity is expedient. But I believe strongly we also need to do more than what we're doing. And I'm not biased to the hard work he's putting in, because except we understand the complexity of the problem and intentionally tackle it from grassroots, we may be cutting off the top and leaving the down unattended to. I'll give you an example. Now, it's not news that you can literally have CS for free if you have yourself well arranged and incorporated in a structure happening in my beautiful Lagos State.
With the insurance?
Yeah, not really insurance. Lagos State have a policy that if you register, you will have just a little to pay, and all your antenatal visit is covered by Lagos State. Okay. Very legal, including cesarean section. And it works, actually. It's confirmed at the public sector. But I flipped back at Sierra Leone, where I was privileged to support them post-Ebola, and I realized that there are a lot of things happening against that at that level. Because when we now go to the level of offering service totally free, the doctors take advantage of it. And then in Sierra Leone, they make a lot of kill that I won't want to repeat it because it's unheard of, because it's completely free. Then doctors will see patients at their mercy and do whatever they like with them. So that balance is also very important. I want us to know as a nation, we need to address the medical issues as a state of emergency issue and start from understanding all the complexity of the issue. We are talking more about the policy part. The process of even the death of the pregnant woman is another subject entirely, which I will mention briefly. Is very important. Most cause of death is bleeding, postpartum hemorrhage. Next to that is infection, in importance. And next to that, is pregnancy-related hypertension. Now, these problems are so deep that if you want to address whatever we're doing, we need to also break it down to, okay, how are we going to stop bleeding in pregnancy? How are we going to stop infection in pregnancy? How are we going to stop hypertension in pregnancy? Of course, the fourth is a teenage pregnancy, pelvic disproportion, making delivery impossible. So we need to break it down there. And when the lady is bleeding, how soon can he get to the nearest hospital? Another issue. So transportation comes in. The person gets to the hospital, there's a blood bank. She needs blood, but there is no power for a long while. So blood bank cannot work in most places. Another major issue. So I'm saying it's a complex issue. We need to raise the standard of living so that some things become easy. Then we can now go to deal with another level of the problems, and then we can move away from here.
Okay. You know, when you say some things, I just wonder, oh God, what is going on? Education is important. Awareness is really very important as well. So as much as, you know, the women that are able to attend their antenatal classes as at when due, what's your advice this morning as to the kind of information they should be privy to? Because again, there is no ignorance in law. You can't say you do not know. So what are some of those things that they also need to look out for that maybe they're not privy to, so that they can ask for help early enough? Because again, sometimes you hear things like only if she had been brought earlier, only if she had we had known that she was going through this. So what are some of those things that the nurses and the midwives also need to continue to cascade to these women, especially at the community level?
Okay, so first and foremost, WHO require everybody pregnant to please attend antenatal visits. Like that's the barest minimum. They should try. Now, the personnel they meet is another subject entirely. It could be a midwife, it could be a nurse. WHO allows it actually for realities. So there is something called triage. If somebody comes in and a midwife is comfortable with the care, fantastic. But they must be with the midwife first. So if the midwife discover what we call high-risk pregnancies, she will now push it forward to either a medical practitioner or an obstetrician and gynecologist, subject to availability. So first things first, pregnant women should please attend antenatal visit. It's in their best interest. Please, it doesn't translate to CS all the time. Please. They should keep that at the back of their mind. You and your doctor will have an interaction in the or your caregiver in the course of your antenatal visit. Please, all pregnant women should please use their multivitamins. They should please use their multivitamins. I should say it aloud. Pregnant care is fantastic, it's expensive, but for blacks, it's not the best. It doesn't supply enough nutrients pregnant women need. They will need to complement it. Let me just say that out.
With other vitamins.
Yes, please. Pregnant care is not for us. We have a lot of deficiencies in blood that pregnant care is for Caucasians. But for us, we need to still add something to it. And this is something everybody must learn since we are now educating. And then please, when you come for antenatal, WHO demand you have at least 4 scans in the course of your pregnancy. Please try and do that for me so that we can prevent the unpreventable. If you notice that your leg is swollen, it could just be part of pregnancy, but it could also be the earliest sign of preeclampsia, which is, as I said, the third most valid cause of pregnancy-related death. So if your leg is swollen, please go for your antenatal visit and let them take care of you. They'll probably check your urine and see there's protein there and advise you accordingly. It's not a death sentence, but we need to know exactly why your leg is swollen. And then please don't use drug in pregnancy except prescribed by doctors. Please. Don't just go to a pharmacy and say, I have a headache. Because not all drugs are safe in pregnancy. Beyond that, please try hard to empower yourself with preparedness for the 9 months. Yoruba would say a 9-month guess is not a guess you are not prepared for.
And we've been seeing that lately. So you need to get prepared.
Okay, Doctor, aside from women going for their antenatal now, let's also talk about the attitude of some of these health practitioners. Because when you mention pregnancy-induced high blood pressure, bleeding, it was just like you saw what I experienced. My wife wanted to give birth. It was a CS, nicely done. Then overnight, she developed complications and she started bleeding. And we had to move from a particular government hospital here to the island. And then we got there. The guy that was on duty, she's bleeding. She was brought in with an ambulance. And the guy was like, please, you have to go and register first. And somebody was dying. So how do we begin to reorientate rather some of these health practitioners in such a way that when they see danger,
when there's an
they will know it is
emergency.
danger. I had to naked myself and box the guy.
You boxed him.
I did.
Doctor, please respond to
I
that.
hope police dealt with the assault.
Can you imagine?
The assault?
Yes.
No.
You assaulted the medical.
Assaulted
I
the
did.
doctor.
Yeah, well done.
He saw somebody bleeding.
Please don't do it again, sir.
Okay.
Let's start with you. Now, back to the real issue. So, the point on hand, I don't like the fact that I'm being put on the spot, but I also love it. I've told my colleagues, and when I say this, they go, why are you sounding like this? We doctors will not earn enough till we hone the process of heightening the quality of medical care in Nigeria, and I believe it strongly. We need to know that our colleagues in America, in the UK, are earning that much because they dare not make stupid mistakes. That's a fact. So, where accountability is important, and I challenge us medical sector players. I'm here, if you want to call me. We are not accountable enough. We are a demigod on ourselves. And I challenge us, we should remember we signed a oath. I hope we understand the oath. Oath is something you took, and my own Bible told me, don't take a oath except you are ready to fulfill it. Deep point. Yes, salary is not enough. Yes, you are tired. They are all rhetorics. Your spiritual life is on the line because you sign a oath to put the interest of your patient over above your economic, your religious, or tribal sentiments. Very deep oaths you took. Go and check your Hippocratic oath as a doctor. That said, we're all humans. I'll come back there. Some of them are overworked. Some of them are not experienced enough. Forget about it. Passion is the driver of medical practice. And I tell my colleagues, nobody can pay you well for being a doctor. Go and understand that. If you're looking for money, you're in the wrong profession, period. But if you understand that oath you took, they didn't tell you who will pay you. So remember, you just need to do your own best to the universe and let the universe prove not to pay you. You will have the payment if you do it with your whole heart. You can never miss it. But if you are stealing from your oath, the universe will steal from you, period. That's a foundation to be laid. However, I'm pleading with every sphere of government to please revisit the salaries of doctors. Let me be very blunt, because I know what I'm saying. It's not about me, it's about us. We're all in this boat together. Nobody wants to do more than one job. Go to work 8 o'clock and close 4 and go and sleep. It's fun. But when you know how much you're going to take home and you have demands in your life, and if you're in a garden, you are an upper echelon citizen, the demand on you is higher than even the demand of your peers. And the salary is nothing to write home about. Let's say it clearly. I won't mention it for security reasons. But the reality is that there is a need to review the salaries of doctors. It is long overdue on one side.
Okay.
Also, as I said, patients also need to try and understand the predicament this guy you're talking about probably is in. In the medical structure, it's only doctors. They resume work in the morning on a typical day, ends the work at 9, then resume work again on what we call calls. And then you are on duty to the next morning. Wait for it, you won't go. You still work again. It's called, it's now becoming normalized. I believe strongly it's not right. We're all humans. You didn't get it, sir. Somebody resume Wednesday morning 9 o'clock. At 9 p.m. is on call. That's what we call it. So he's going to stay over. And if he's busy all night, nobody cares. He will still stand up 8 o'clock, go and bathe and resume work. And you're coming in 8 o'clock, you're meeting a man that has worked non-stop for 24 hours. I'm sorry, he cannot deliver as well as me coming in 8 o'clock to meet you. That's a fact. Another part that we need to squarely consider. I don't know why it's now normalized. I don't think it's normal. I think it should be revisited. For example, our nurses, our colleagues at work, they don't do that. They have shift.
But then that's why they are nurses, and so they are also asking that they be treated like doctors.
I don't mind if they can at least
they can also
put in the
deliver
training.
like that.
It's okay. We're all here to collaborate.
Yeah, but then, I mean, so just again, before we let you go, addressing Jibala's question, how much of because again, there's an oath signed, and so if you're tired, do you is that on the patient?
No and yes.
Explain.
He's human, for crying out loud.
Yes, he's human, but then he's there.
It's not on the patient, but he can only do as best as he could.
Can he be sympathetic?
I love that question.
So let me go deeper into this matter both of you are putting me on the spot to do. I analyzed my life as a doctor. I was privileged to do my house job at St. Nicholas. And it set the pace for all my practice. So my approach to patient care is completely different. And I challenge us, that's where the problem starts from. An house officer in most government hospitals, most without exception, they see patients as pests. They see patients at their mercy. That's a deep thing, actually. Unfortunately, or unfortunately for me, at St. Nicholas, I see big people in 2005 where it's not HMO driven. You cannot come to St. Nicholas except a millionaire. And I'm just a French doctor. So I sit in front of the movers and shakers of the community. I feel like I want to be like them. You understand what I'm saying? Somebody told me he's a doctor and a lawyer when I was attending to her, and she was 40. And I'm like, okay, I want to be like that at 40. So my approach to patient care changed right there, and it's still part of with me. Okay. Patients, according to our books, Hutchinson Clinical Method, says patients are the queens in interaction. That's theory. Because the reality of an house officer is that they are gathering funds to save a patient. So that's a peasant. And it goes a long way to shape how we see patients for the rest of our lives. And these are facts.
So do you also recommend a change or a shift that way? Because, I mean, earlier you did say that doctors can only get paid. It's just like footballers. Sometimes you see that footballers in some international teams get paid good money. And
ridiculously, actually.
And some will say I'm not, and I'm saying, are you putting in the same energy
you can't.
that guy is putting in?
You can't now.
You can't now.
Yeah, that's a training.
So, are you advocating for better care, which you've said here? And so, even if you're getting better pay, how about the structure? Can we also begin to be more humane in our dealings with the patients?
So I'll tell this anytime I have the opportunity. We need to revisit our curriculum as medical trainees and trainers. Okay. We are leaders by training. By default, doctors are the leader of any medical team. But how equipped are we to lead?
In terms of psychology?
Mindset and the principles of leadership.
Right.
You are not a leader because you are in a position. You are a leader because you understand what it takes to lead.
Right.
That's one. Our management skills leave a lot to be desired also. Our emotional intelligence leaves a lot to be desired also. And I say it properly, our financial intelligence also leaves a lot to be desired. So it's not even about salary. It's about we are pushed out, feeling we are in charge, but we don't even know what we are in charge of. Okay. And that's the main issue. So I don't know how our medical curriculum could be incorporated to put deep leadership into the training, put deeper emotional intelligence into the training, put deeper management capacity into the training. I can assure you, I passed the training at both under and postgraduate, that pace is still quite vacant.
But is there any kind of induction or training after school, before you start to practice?
Yes, it's called internship. It's called housemanship. As I said, that is where you lay the foundation for the type of doctor you'll be. I'm saying not everybody is as privileged as me, though the privilege to me then was a disadvantage, because openly St. Nicholas was paying me 60,000 then, and my colleagues in Lut were earning 120 that year. So I thought it was a disadvantage, but in retrospect, I am under the great Ebobang Boye, who is one of the greatest nephrologists, teaching me how to treat kidney patients personally. It will go a long way than having 12 interns under the same Ebobangboye if it's in the practice. And you have to coordinate all of them. And don't also forget, we don't even have enough space for our graduating doctors. So it's a complicated issue. I insist we are in a state of emergency medically, and the earlier we go and revisit all these details, the more we get the desired result.
All right, Dr. Giwa, before we allow you go, let's quickly go back to the case at hand. And again, in case there are pregnant women watching, or we know anyone, let's see, what are some of the signs that you should look out for that could put your pregnancy and yourself in danger, whether or not you're up to term or not even up to term?
First things first, we talk about multi-gravida. Those that have been pregnant and delivered more than 4 times.
Okay.
It's a risk on its own. You are more than 35 years old. It's a risk on its own. You are less than 20. It's a risk on its own, without any other thing being wrong. So if you come from an antenatal visit and I have you and you meet this criteria, if I'm a midwife, I should transfer you to a doctor. For these ones alone. Now, if I'm a doctor, I evaluate you, I say, this one, there is another thing. I'll transfer you to a gynecologist.
Okay.
That goes a long way to leverage the quality of care you get. At each of these levels, from a midwife to a doctor to a gynecologist, there is heightened skill and competence to deal with potential complications. So that's one. Two, if you feel unnecessarily weak and it's new in the pregnancy, it may be the fact that your blood count is low, please go do antenatal care. And when you do that, you're in the best position to help make things way better. Beyond that, if for any reason you feel that, okay, why am I, if you see show or you are seeing water flow at any point in your pregnancy, other than when you're at term and you saw show, you're better off being aware that it's time to go for your antenatal visit. Please make sure you go to antenatal visit as at when due, and please submit yourself to interacting with your caregiver to plan your delivery.
Okay.
Don't run away after antenatal.
All right. All right. Thank you so much, Dr. Temitayo Giwa, for finding time to be here on the program today. Medical doctor and president, JP Foundation. We appreciate your thoughts on the program today.
Thank you so much.
All right. So we would need to go. That's our peace offering on the program today. Joy Ajibola, of course, the show will be here tomorrow. We'll need to link up now with our colleagues at the Bagauda Council Press Center at the Lausa, of course, where the Lagos State Commissioner for Health, it is the turn of the Minister of Health at the ongoing ministerial press briefing 2025. We'll leave you now to the live feed that event. Joy and Ajibola, say your goodbyes, and then we're out.
All right, thank you very much for watching the show today. We'll see you again tomorrow at 10.